This conference will now be recorded.
Students already open, na? ఏంటి ఎంతమంది వచ్చారు ఏంటనా ఏంటివి అలా ఓపెన్ చేసిన వాళ్ళ ఏంటివి
ఓపెన్ చేసిన
హలో
sir.
Today you will discuss about the renal tuberculosis and hydronephrosis. Okay. So this commonly they are asking in the examination. Something you have to know regarding tuberculosis and the hydronephrosis. Hello. Yes, హలో
Yes, sir.
స్క్రీన్ వస్తుందా మీకు స్క్రీన్ కనిపిస్తుందా
Yes, sir. Yes, sir.
కనిపిస్తుంది సో టుడే I have to discuss about the Dr. Rambabu, professor of surgery, taking the class today regarding renal tuberculosis and hydronephrosis. Okay. So renal tuberculosis of the kidney is only always invariably secondary. So the primary focus may be somewhere. Mostly the primary focus only present in the lungs or in maybe intestines or in the bone. Okay, the primary renal tuberculosis is very rare. So the tuberculous bacillus can occur in the early lesion of the cortex. So whenever the tuberculosis develop in the kidney, usually it starts in the renal cortex. Then it spreads from the cortex to medulla, medulla to renal pelvis, through ureter it enters into the bladder. So when it enters into the ureter, it may produce the tuberculous ureteritis. Once the inflammation of the ureter can occur, later it may develop ureter stricture. Okay, it's always secondary, not a primary. Remember. Hello, Rajesh. So this is the diagram showing primary focus is present in the lung and it spreads through the hematogenous spread. It may reach to the renal cortex. From the renal cortex, it again into the medulla, renal pelvis, and enters into the ureter. From the ureter, it enters into the gallbladder. Okay. So what is the pathogenesis? So hello, Rajesh. So what is the pathogenesis? So commonly this bacteria when enter into the kidney, it enters to the passes to reach the glomeruli and the tubules. From the glomeruli, it produces the Langerhans giant cells. Hello. బ్లాక్ బాటిల్ పవర్ ఏది
సార్ వస్తుంది
వస్తుంది అది దాన్ని ఏం చేయాలని నాకు తెలియట్లా.
చెప్పండి.
హలో, ఆర్ యూ విజిబుల్? పైన ఒకలా.
Yes, sir.
Now we have to talk about the pathogenesis of the renal tuberculosis. So once the bacteria enter into the kidney, it enters into the glomeruli. From the glomeruli, it enters into the tubules. So where there is some pathogenesis can occur. Usually the tuberculosis containing the Langerhans giant cells. When you examine histologically, the glomeruli containing the Langerhans giant cell and epithelioid cells. Okay, these granular giant cells may enter into the ureter and produces the ulcer. So what are the various conditions related to the tuberculosis? Tuberculosis papillary ulcer and cavernous form and hydronephrosis. So this is the diagram representing the things. Next, pyonephrosis. It is also due to the secondary spread by the infection by E. coli and Klebsiella. Next, it may turn into a tuberculous perinephric abscess. Perinephric abscess. And sometimes it may be calcified. In some area of the tuberculosis of the kidney may be calcified, mimics like a caliculi, renal caliculi, or it is also known as pseudocaliculi. Once it is not treated, caseation has been taken place in the kidney. So that is called caseation kidney. These are the varieties of the kidney, tuberculosis of the kidney. So the caseous kidney is oftenly called putty kidney or cement kidney. Automatically it may autolyzed. Later, ultimately, it may produce the miliary tuberculosis. So many particles may develop in the kidney itself. That is called renal tuberculosis. These are all clinical varieties. See, tuberculosis cavernous, hydronephrosis, tuberculosis papillary ulcer, pyonephrosis, tuberculosis perinephric abscess, calcified tuberculosis area, caseation of the kidney, and miliary tuberculosis. These are all the pathogenesis has been taken place in the tuberculosis of the kidney. Next, these tuberculosis bacillariae can occur and enter into the stage of the disease which causes the tuberculosis urethritis. Urethritis means from the renal papillae, renal pelvis, and enters into the ureter, produces the tuberculosis urethritis. Once the urethritis can occur, ultimately the strictures may develop. Once the strictures has been developed in the ureter, produces the hydronephrosis. The most common site of the stricture in the ureter is ureterovesical junction. That means when enter into the ureter, when enter into the bladder, that is the site where the obstruction can occur. That is stricture. Is a common site for the pelvic junction. So the ureteric stricture is the common site is pelvic junction. Next, what is the pathology has been developed in the tuberculosis kidney? So tuberculosis cystitis. So tuberculosis cystitis, when you examine the cystoscopic examination, the ureters on either side of the trigone looks like a golf hole ureter or thimble bladder. That is called thimble bladder. That means a small hole can be seen in the upper part of the trigone. That is called thimble bladder. Next, other pathology is the tuberculosis prostatitis. So from the bladder, it may go into the tuberculosis infection to the prostate gland, produce the tuberculosis prostatitis, and seminal vesicles also be involved. When you examine the perectal examination, the seminal vesicles are enlarged and form in consistency. And not only the seminal vesicles, later tuberculosis epididymitis and folliculitis, that means spermatic cord, can occur. This is the other conditions of the tuberculosis infection from the kidney to other parts of the genitalia. So you see, these are the various pathological conditions of the tuberculosis. Tuberculosis hydronephritis. Because of ureteric stricture, the kidney has been enlarged. Tuberculosis advanced stage, it may go from the cortex to the periphery of the kidney. That is called perinephric abscess. Cavernous worm. So in the cavernous worm, one pole or upper pole or lower pole, the cavity may develop within the kidney, cortex and medulla. Is the tuberculosis cavernous. Next, calcification. Sometimes the long-standing tuberculosis kidney calcification can occur. You can take an X-ray. The calcifications can be identified in the plain X-ray of the abdomen. So the calcifications can be seen in the cortex of the kidney. Next, caseation. So caseation means disintegration. All the tuberculosis glomeruli all are disintegrated by pus. Caseation, that is called disintegration of the tuberculi of the kidney. The other thing is the entire kidney may be small miliary tuberculosis. Small nodules can occur in all part of the cortex medulla of the kidney can occur. These are the various stages of the tuberculosis of the kidney. So what are the clinical features? So commonly seen in male patients rather than the female. Right side is more common than the left side. So frequency, patient may develop a frequency of micturition throughout the day, both the day and night time. So polyuria, so passes the more amount of the urine. This urine is, when you culture, no bacteria can be seen, that is called sterile pyuria. Sometimes painful micturition can occur due to the hematuria. So the hematuria may be a macroscopic. Macroscopic means less than 5 RBC can be present in the urine itself. It should be diagnosed under the microscope. So microscopic hematuria can occur when patient is having suffering from the tuberculosis of the kidney. Patient may have renal pain. Sometimes suprapubic pain. Why suprapubic pain can occur? Because from the ureter, kidney through the ureter and enters into the bladder. So the bladder is situated in the upper part of the pelvis. So patient may have a suprapubic pain. Suprapubic pain more commonly due to the cystitis, the involvement of the or inflammation of the bladder. Next, when you palpate the kidney, is not easily palpable in the tuberculous kidney unless there is a pyonephrosis or hydronephrosis. When you do the perilectal examination, there may be enlargement of the prostate, seminal vesicles can be seen. When you palpate the spermatic cord, the vas is thickened and beaded in appearance and thickened epididymitis. So once the tuberculosis can occur, patient may have impotency and the features can be seen when the tuberculosis kidney is there. Sometimes patient presented as a acute pyelonephritis. So what are the symptoms, signs are there in pyelonephritis? They mimic the same diseases of the tuberculosis of the kidney. In long-standing cases, there may be some signs of development of urinary stones. So this urinary stone is mainly due to the urinary tract infection. A recurrent urinary tract infection may likely to develop the urinary stones. So once the renal failure, renal stones occur, hydronephrosis, and patient may go into the stage of renal failure when the both kidneys are involved. These kidneys are usually leads to hypertension. Certain constitutional symptoms may develop, loss of weight and fever will be there when the patient is suffering from tuberculosis of the kidney. Next, sometimes primary process may be present in the lung, so that patient may have a hemoptysis and cough with expectoration. So these are the clinical features of the tuberculosis of the kidney. So how do you investigate? How do you manage this case? You have to do some investigations. Important is the hemoglobin. So why hemoglobin is important? Sometimes the patient is having hematuria, so that there is a blood loss. So the hemoglobin level has come down. So you should estimate the hemoglobin. And whenever tuberculosis is there, ESR is raised. Erythrocyte sedimentation rate has been raised. Normally it is 20 mm per hour, but it may go up to 40 to 50. Whenever there is a tuberculosis, the ESR is enormously raised. And Mantoux test, skin test is also usually positive. So you give a small injection in the subdermal region and wait for 4 days, 72 hours. So then maybe increase the spot of the injected site. When you take an X-ray, chest X-ray also to be taken to know any focus in the miliary tuberculosis of the lung is there or not, you can detect by the taking chest X-ray. Next, ultrasound. So ultrasound of the abdomen is also important to know which part of the kidney is involved, either cortex or medulla, or any calcification is there, any perinephric, any cavernous or caseation can occur, you can detect by the ultrasound of the abdomen. Next, we have to collect the urine samples. So early morning urine samples, minimum 3 samples to be collected from the urine and send it for microscopic examination for any tuberculosis bacilli is there or not. The same urine can also send for culture. The culture media is LJ media to detect the growth of Mycobacterium tuberculosis. And microscopically, you can also detect by doing a Nielsen's staining. So urine should be collected, samples and sent for microscopic as well as the culture of the urine for tuberculosis organisms. I already told you that the plain X-ray of the abdomen or KUB, kidney urinary bladder. Sometimes calcification can be seen either in the kidney or in the ureter or in the bladder. Okay, these are the investigations to be done. Another sophisticated investigations like tuberculosis CT, plain or contrast CT to be done, either pelvis and the abdomen. See, look for any hydronephrosis or shrunken kidney or any strictures in the ureter, any necrosis in the kidney itself. In the cavernous form, you can see necrosis. The other investigation is intravenous urography. What is the advantage of doing this investigation? To know any hydrocalyx, hydronephrosis is there or not. You can see any stricture of the urethra, you can identify by doing this intravenous urography or pyelography. Next is the cystoscopy. So multiple tuberculosis is present in the bladder wall, in the mucosa of the bladder. So the bladder go into the stage of spasm and edema of the ureteric orifice. When you examine through the erythroscope or cystoscope, you can see multiple tuberculosis present in the trigone or bladder mucosa, and bladder is contracted and edema has been seen on ureteric orifices. This is called golf hole ureter. Sometimes they ask a 2 marks question, you should write golf hole ureter is seen in the tuberculosis infection of the kidney. When you examine the cystoscopy, there may be a tuberculosis, biliary tuberculosis present in the multiple tuberculosis present in the trigone and the inner mucosa of the bladder. There is a spasm of the bladder and edema has been identified on either side of the ureteric orifice. That is called golf lobe ureter. Okay. So this, if we are not going to treat, what happened? There may be some scarring of the bladder can occur and ulceration has been developed, and ultimately stone formation and bleeding can occur. These are the consequences by the tuberculosis of the bladder. And another is also can be identified by the polymerase chain reaction and MCU. MCU means micturating cystourethropy or voiding cystourethropy. This is very useful to identify the any ureteric stricture or reflex. So these are the investigations. CT abdomen, intravenous urography, cystoscopy, and PCR and MCU. MCU means micturating cystourethropy or voiding cystourethropy to detect the ureteric orifice, any ureteric strictures and reflex of the urine. So how do you treat this case? So you know all the treatment mainly it is treated by the anti-tuberculosis drugs like INH, rifampicin, ethambutol, pyrazinamide. So the treatment to be continued minimum 1 year to be given. Okay. So once the patient is suffering from the tuberculosis of the kidney, so after giving the treatment, after the starting of the treatment, minimum 12 weeks of the drug to be given. Later he should plan for any surgical plan should be to be done. Why you have to do surgical plan? Suppose patient may have a pyogenic nephrosis, tuberculosis pyogenic nephrosis. If you leave it like that, patient may go into the stage of renal failure. In such conditions, you have to intervene, the surgical intervene to be done. So you should give the incision and drainage and let out all the pus from the kidney. So after giving minimum 3 months of the anti-tuberculosis drugs. So that is another procedure is polycalcix is drained. That means kidney is exposed and cut edge of the capsule is sutured. Okay. So that is called Hanley renal cavernostomy. अच्छा. Okay, there are various surgical procedures. One is the conservative treatment to be given first initially anti-tuberculosis drugs minimum 1 year. If any abscess is there after the 3 months, 3 weeks of the 3 months of the drug therapy, should enter in the surgical procedure. And another is when the kidney is involvement of the any pyocalix, you should do Hanley renal cavernostomy to be done. In case of hydronephrosis, you should do hydronephrosis can occur, because of some tuberculous ureteric stricture or pelvic stricture. So it may produce the hydronephrosis. Urine will not go from the kidney to bladder. So that hydronephrosis. Once you diagnose the hydronephrosis, you should do Anderson-Haynes operation. If it is not possible, you should do nephrostomy. That means you have to make a hole. Percutaneous nephrostomy should be done, or you can put a J stent. If the ureter, through the ureter, you can put a J stent and let out all the urine which is collected in the kidney. That is treatment for hydronephrosis. So the hydronephrosis is also one of the complications of the tuberculosis of the kidney. Okay. So this is the tuberculosis of the kidney. So how you will manage if the renal abscess is there? If it is not resolved even for the medical treatment, you should go IND. Okay. Next, I already told you, urethral stricture can occur. How do you do how you will manage the urethral stricture? Either stenting or reimplantation of the ureter into the bladder or psoas muscle, or Boris flap method, or ileal conduit. These are all the surgical procedures when the ureter stricture is there due to the complication of tuberculosis of the kidney. Next, thimble bladder. What is thimble bladder? Already know. So because of tuberculosis of the kidney, all miliary tuberculosis present in the mucosa and gulf hole ureter can occur. So in such conditions, you do hydrolytic dilatation or ileocystoplasty or cecoplasty. That means the bladder is connected to ileum, or bladder to be connected to the cecum. That is called cecocystoplasty, or to the sigmoid colon, or sigmoid colocystoplasty is to be done in case of thimble bladder. Okay, if it is a unilateral lesion with a gross impairment of renal function, you should do nephroureterectomy. You remove the kidney and along with the upper 1/3 of the ureter to be done. When the gross renal impairment is there, you should do nephroureterectomy to be done. So this is the surgical procedures of the management of tuberculosis of the kidney. Suppose if the obstructive uropathy is there, how we will manage? So the urinary to the normal blood flow. The main pathology is to remove the obstructive urinary flow. How do you manage the obstructive uropathy? Refers to the renal disease caused the impairment flow of urine or tubercular fluid. Hydronephrosis. Hydronephrosis to the aseptic dilatation of the urinary tract. These are the various surgical intervention for the tuberculosis of the kidney. Okay, are you understand? Hello? 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 Next, we have to talk about the hydronephrosis. So hydronephrosis can usually ask as a long essay question or a short notes. So you need to know something about the hydronephrosis. What is hydronephrosis? There is a aseptic dilatation of the pelvic calcium system, either partial or this is also one of the complications of the renal tuberculosis. Hello? Hello?
Sir.
Hydronephrosis, you should read something about the hydronephrosis. So what is the hydronephrosis? It is the aseptic dilatation of the pelvic calcium system due to either partial or intermittent obstruction of the urine. So what is the etiology? So it may be unilateral or bilateral. Most commonly is the unilateral. So what are the causes for the development of unilateral? It may be extramural or mural. So what are the causes for extramural causes? One is aberrant renal vessels, especially either artery or the vein, commonly present in the left side. So there is apparent renal vessel, sometimes encircle the ureter. So once the ureter is encircled, so there may be some obstruction of the urinary outflow. So there is likely to develop the hydronephrosis. That is one of the cause. Next, the compression of the ureter. It may be a carcinoma of the cervix or carcinoma of the rectum. So the surrounding structures may be any malignant growths are there either from the cervix or the rectum. They are exert the pressure over the ureter and compresses the ureter may leads to hydronephrosis. So hydronephrosis means simply you cannot remember to prevent the passage of the urine. Next, any retroperitoneal is usually retroperitoneal organ. So any retroperitoneal lipoma or retroperitoneal neuropathy may also produces the pressure over the ureters, produces the hydronephrosis. Next, retrocaval ureter. Retrocaval is also none of the aberrant ureter. Sometimes the ureter passes behind the inferior vena cava. So once the inferior vena cava, some obstruction occur. That is called retrocaval ureter. These are all the conditions which are respondent of hydronephrosis. What are the intramural causes? Extramurally, now we have discussed. What are the intramural causes? So intramural causes usually a congenital PUJ, pelvic junction obstruction can occur, or uterocele. The mucosa of the bladder can produce the inner bladder, inner mucosal layer of the bladder may produce the cyst that is called uterocele, or any malignancy related to the ureter that is also responsible for the hydronephrosis. Ureteric orifice is narrow either from the bladder itself or from the urinary pathway. Okay, narrowing of the ureteric orifice or internal stenosis are responsible for the hydronephrosis, Golf hole process. Next, within the ureter, suppose ureteric stones are there. There may be dislodged pelvic junction may causes the hydronephrosis. It is intramural. Intraluminal. What are the causes? Intraluminal means within the lumen of the ureter or renal pelvis. Any stone or pepper may produce the obstruction. So intramural, extramural, intraluminal causes for the development of hydronephrosis cause etiological factors. So if it is a bilateral, so hydronephrosis is usually always unilateral. If it is a bilateral, what are the conditions to develop the responsible for the development of bilateral hydronephrosis? It may be congenital or acquired. So congenital means congenital stricture of the external urethral meatus, pinhole meatus. I already told you. So when there is a pinhole meatus in the male or female urethral orifice, may produces the both kidneys are involved, because the both kidneys, the urethra is extending from the bladder to the exterior. So there is a sense or congenital posterior urethral valve. So these two conditions produces the bilateral congenital hydronephrosis. Or acquired diseases like benign prostatic hypertrophy or carcinoma of the prostate or postoperative neck bladder scarring. These are all bilateral causes for the development of hydronephrosis. Or any inflammatory conditions of the urethral stricture, phimosis, carcinoma of the cervix, carcinoma of the bladder. These are all conditions which are responsible for the development of hydronephrosis. See, this is the kidney, enlarged kidney. There is an obstruction at the pelvo-ureteric junction. So there is a renal pelvis. The renal pelvis is dilated. The entire kidney, the urine output is not going up, down. So it is accumulated in the kidney itself. That is called hydronephrosis. It's a congenital variety. Next, oftenly bilateral, present in the one side than the earlier than the other side. If it is a bilateral, both sides may not come at the same time. So this is another picture showing the aberrant. You see, the ureter passes behind the renal cava, aberrant vessel. It is also one of the cause for the hydronephrosis. These are the pictures diagramming showing the hydronephrosis. So how you will treat? Suppose if the renal vessels are there, you should cut down the vein safely, but should not cut the artery, because you should be pull the artery or push the kidney downwards and to separate from the ureter. So vein you should be sacrificed, but artery should not be sacrificed. Once the artery is sacrificed, there may be some ischemia can occur. So there may be some chance of damage of the kidney. So you should not cut the arterial blood supply. Next, the another procedure is called Hamilton-Stewart operation. What is that Hamilton-Stewart operation? Here, the kidney is mobilized. The upper pole and lower pole are approximated together so that the artery is made to slip away from side to the compression. So renal, that is aberrant renal artery compression is there. That should be mobilized the kidney upper and lower pole and separate from the obstructed portion of the artery. That is called Hamilton-Stewart operation. Okay. What is the pathology? Pathology of the hydronephrosis. Initially, this pressure has been taken in the pelvis, later renal pelvis, later calyces and parenchyma, so that the kidney is going to be enlarged gradually. So parenchyma is thinned out due to the destruction and its dilatation into its dilatation. So leading compromise the secretory function. So once the parenchyma is stretched out, the secretory function is also being damaged. The parenchymal thickness is less than 2 mm is likely to be unlikely to be function. So in bilateral cases, such patients will go renal failure. So that is the pathogenesis has been taken place in the kidney. So what are the clinical features? So it is unilateral or bilateral, we already discussed. When it is unilateral, when there is a congenital PGA obstruction or calculus can cause the kidney can be palpable in the loin. So males are more commonly affected than the females. The ratio is 2:1. Which side kidney is more affected? Right side kidney is more affected. So patient have a dull aching pain in the loin and dragging sensation can occur in the loin and feel of heaviness in the loin. So you can palpable the mass. That mass may be smooth, mobile and moves with the respiration. So you know what are the structures which are moves with the respiration? One is the kidney, liver and spleen are moving with the respiration. This patient may have acute renal colic. Why? Because there is some stones may develop because of retention of the urine may produce the renal colic may develop. What is the diabetes crisis? Sometimes they ask you a short notes for the diabetes crisis. Is oftenly patient is suffering having a diabetes crisis. That means after an acute attack of renal colic. So patient may have a renal colic, but swelling can be seen palpable in the loin. But after some time it may be disappear because of passage of large volume of urine. That is called diabetes crisis. That is seen in due to the presence of Gulf hole ureter or hydronephrosis. So initially there is a lump present in the kidney and patient may have a pain in the loin, but gradually it is disappear because of passage of large quantity of urine from the kidney to the bladder. Next, patient another conditions like dysuria, hematuria can occur. Tenderness may be present when there is a urinary infection has been taken place. Patient may have gestational hypertension. So these are the features of the hydronephrosis. Patient may have hypertension, hematuria, loin pain, palpable lump in the loin. Suppose if the bilateral cases. So what are the clinical pictures when patient is having bilateral hydronephrosis? So the causes which are responsible for the lower urinary obstruction. Lower urinary obstruction means from the urethra and the ureter and bladder, patient may have a pain in the loin. And features of the bladder outlet obstruction like frequency, hesitancy, and pure stream can occur. So that what happened? Renal failure has been taken place, and both kidneys are palpable. So that is called lower urinary tract obstruction. That means from bladder to urethra. Next, bilateral upper urinary tract obstruction. So similarly, patient may have pain. If it is a bilateral upper urinary tract infection, what are the symptoms patient may have? Patient may have a pain in the loin region. Mass is palpable due to the attack of colic. If it is a bilateral, patient is severe and renal failure is likely to develop. Patient may go into oliguria stage and later patient may develop weak cough and edema. Ultimately, it lands on the complications of renal failure. So bilateral hydronephrosis is very dangerous. You should take care of immediately. So what are the complications? So once the hydronephrosis means that is the urine collected in the kidney, but it is not treated properly. It may stay into the pyonephrosis where it may get infected and ultimately to develop the pyonephrosis means pus in the kidney itself. Next, perinephric abscess. If the go on stretching of the capsule, what is going to happen? It rupture through the cortical region and reaches to the perinephric region. So in and around of the kidney and ultimately renal failure. These are the complications of the hydronephrosis. So how do you treat? how do you investigate? So blood urea, serum creatinine, and urine microscopic examination, an ultrasound of the abdomen to know which type of the kidney is involved, site, and everything you can know by doing an ultrasound, and intravenous urography. So what are the findings by giving the intravenous urography? Normally it is a cupping in nature. Once the pathogenesis has been taken place, it becomes a flat and it becomes a club. It is cup shaped and flat and club. So broad, this cup is gradually broadened. So these are the changes has been taken place when the kidney itself. Intravenous pyelography findings. You see, this is the cupping. So already club is divided. It is a clubbing. That is the IVP findings. CT is showing the enlargement of the kidney. Hydronephrosis. So isotopurinography done. DTPA means diacetylene triamino pentaestic acid is given to know the functional status of the kidney. So Whitaker test. This is a one test maybe also to know whether the hydronephrosis is there or not. Here, what you have to do, fine needle has passed into the renal pelvis through the loin, and pelvis is perfused with the saline at the rate of 10 ml per minute. Normally, initially the pressure is increases, but later it will remain constant. So persistent increasing is the suggestive of hypertension. That is Whitaker test. How do you treat this case? The treat to the cause. Suppose if it is a phimosis is there, circumcision, BPH is there, TURP, posterior urethral valve is there, you should do congenital surgical procedures to be done. Aberrant vessels are there, you should treat aberrant. Stones are there, you should remove the stones. If it is not possible, you should do ultimately the nephrectomy should be done, ultimate condition. So the other procedure is Anderson-Ains operation. It is dismembered pyeloplasty. Here the pelvis is enlarged, renal pelvis. The pelvic wall should be, renal pelvic wall to be cut down, the enlarged part, and we anastomosed it like this. This is called Anderson-Ains operation. Here pelvic ureteric junction obstruction, the spasmodic segment are excised. This is the redundant pelvis are to be excised. The new pelvis is created and cut end of the pelvis is anastomosed to the ureter. So this is the cut end of the penis, renal pelvis to anastomosed to the ureter like this. That is called Anderson-Ains operation. Next, Davis tube ureteroscopy and Foley's valvoplasty. These are the various procedures toward the hypertension, hydronephrosis surgery procedures. Next, if it is hydronephrosis bilateral without renal failure, the kidney is functioning and better should be operated first. Which is the first is there, that should be operated first. After 3 months, the other kidney to be operated in case of bilateral hydronephrosis. Okay. So in bilateral hydronephrosis, the renal failure has been developed. Bilateral nephrostomy. Nephrostomy means the opening of the kidney and remove all the fluid present in the kidney itself. That is called hemodialysis may be required sometimes. After 3 to 6 weeks, IUU, it means intravenous urography to be done to know the functional status of the kidney. Next, laparoscopic may be also be done for the hydronephrosis, and endoscopic pyrolysis can be also be done for hydronephrosis. Okay, next class we can talk about the pyonephrosis and other things. Okay. Hello. Hello. Shall I continue? Hello. Hello.
Sir,
Shall I continue or stop it here? Still 5 minutes or
at
more?
11:30 we'll have another class, sir.
Another class is there, huh?
Yes, sir.
Okay, next class we can discuss about the other remaining pathological conditions like pyelonephrosis and all this. Okay?
Okay, sir.
Thank you.
Okay, sir.
Any doubts are there?
No, sir.
So commonly you should read thoroughly about the hydronephrosis. This one, pyelonephrosis and tuberculosis of the kidney. Commonly they are asking the examination. Okay?
Okay, sir.
So you have some idea and go through and read the textbook. Thank you.
Thank you, sir.